Thank you, Dr. Atik, and thank you, Eden. Really great to be here today. So before we get started with our panel, I'm just going to talk for a few minutes about what exactly is harm reduction, what an example of harm reduction can look like, and how we can begin to integrate harm reduction in a clinical practice on a very high level. So next slide. So there are many different definitions of harm reduction out there. There's no one correct definition. You may have heard harm reduction in the context of things such as sex work or COVID, which is valid. Today, we are going to be focusing solely on substance use. So drugs have been used in every society throughout all of history. And, harm reduction is not necessarily radical acceptance. It acknowledges that there are real harms of both drugs and their policies, and these harms disproportionately impact people of marginalized groups, particularly people of color, trans and queer folks, disabled folks, people of low income. And harm reduction is really working towards any positive change. And it really needs to center the needs and voices of people who use drugs. So not just consulting, but meaningful decision-making power in individual, community, and institutional level harm reduction practice. So there's nothing about us without us. It's not necessarily a specific intervention. There are interventions that can reduce harm, but if you designed a new syringe exchange that was not very accessible by public transit and required multiple forms of government ID, you might not be reducing that much harm because you'd be excluding many of the people who need that service the most. So next slide. So again, harm reduction is a continuum. It is a spectrum of behaviors and outcomes. And we're really looking towards any positive change, even if it's very small. So as we can see here, there's many ways to practice harm reduction in the context of substance use outside of injecting. But generally speaking, injecting drugs is more risky than not injecting drugs. And I don't think I need to explain to this audience why, something like sharing syringes is a higher risk substance use practice. And if somebody is going to inject, and there are many valid reasons why people do choose to do that, the ideal outcome would be to use a sterile syringe every time, right? But what if you were working with someone in a rural area who maybe the nearest syringe exchange was an hour away? Syringes weren't sold over the state in pharmacies, over the counter in that state. In that instance, I might counsel that person on these are best practices for sterilizing syringes with water and bleach. This is how we rotate veins. Again, moving from that sharing with others to reusing on ourselves with sterilization, still a higher risk practice, but it is slightly safer when we're moving on that spectrum. Next slide. So on a very high level, when we think about integrating harm reduction into clinical practices, substance use tends to be viewed as a very all or nothing thing. And it's the only condition where if somebody is not quote unquote successful in treatment, sometimes we stop treatment, which is kind of wild if you think about it, right? If someone presented to your clinic, newly diagnosed with type 2 diabetes, and at their follow-up visit a few months later, after starting medication and counseling them on healthy eating, their A1Cs were still elevated, you wouldn't stop treatment for them, right? You would adjust medication, make sure they knew how to use it, hopefully dig deeper into the diet piece. Does this person have access to healthy foods? Do they have good nutrition literacy? And so, we need to really bring that same approach to substance use when we are working with patients. There are very real barriers that many people face in starting and staying engaged in treatment that don't necessarily have anything to do with their motivation to change their use. And so, as clinicians and practitioners, we need to really be able to explore these barriers and motivation. Motivational interviewing is a great tool that both clinicians and non-clinical staff, such as peers and case navigators, can get trained in to help understand what our patients are going through, what the barriers they're seeking, and try to figure out what a successful outcome looks like. And lastly, I do want to think about the concept of sometimes the goal is going to be total abstinence, and that's a great goal, and we should support people in that, but it doesn't have to be the goal 100% of the time. Sometimes the goal is going to be to use just less in a way that is safer and is more, we feel more in control, right? So not all drug use is necessarily a problem. I think alcohol is a really great example. People have lots of different relationships with alcohol, from, very damaging to health, jobs, relationships, finances, etc., all the way to people just casually drinking a glass of wine at dinner every now and then, right? So we don't, there's a huge spectrum of behaviors when it comes to alcohol. We don't necessarily review all of those as problematic or chaotic. So definitely broaden our goals for other substances as well. People use illicit substances all the time in ways that are experimental or social or for self-medication. Yeah, so with that introduction, I want to open it into our panel. We're going to start with you, Dr. Reed. Can you tell us what you are currently doing in terms of your work in harm reduction and what led you to where you are now?
Sure. Thank you so much for having me today. I am currently an assistant professor in emergency medicine at Thomas Jefferson University in Philadelphia. And I also teach at a separate college within the university in the Master's in Public Health program. And I do consider myself a harm reduction researcher. So I mostly work with people who use drugs, mostly doing overdose prevention work and drug checking work. And I partner with them to guide my experience through the use of community advisory boards and things like that. I got my PhD in public health, so I'm in a little bit of a different position within my department. I think I'm the only PhD in my emergency medicine department. So I'm a non-clinician working alongside clinicians and also partnering with them to do hospital-based interventions. I came into public health. My previous career was working as a community organizer. I did housing organizing. And after many, many years of doing that work, the health disparities of the low-income tenants I was working with became very apparent to me. That brought me into a master's in public health program. I didn't even know what public health was before that. And which introduced me to harm reduction, which was a concept that really resonated with me. So since that time, again, I've done a lot of overdose prevention work in jail systems, and I find myself now in a clinical setting in the hospital and thinking about transitions of care for people who are either in the emergency department or become inpatients, and then their transitions out of care, and working within the hospital to improve those transitions at a systems level. A lot of the work that I do now that's near and dear to my heart is drug checking work, which is what I'll be talking about today. I do a lot of work with fentanyl test strips, and which is a piece of paper that you can use to detect the presence of fentanyl and many fentanyl analogs, and then more advanced drug checking work with machinery where people could bring a sample of drugs. You can tell them the full composition of the sample of drugs, what sort of adulterants are there, what sort of fillers are there, so that people can make more informed decisions about whether or not they choose to use the drug and how they choose to use it. So I'll be talking more about that today.
Great. And on to you, Dr. Lattimore. What are you doing in terms of harm reduction in your work, and what led you to where you are?
Yeah, so I'm an epidemiologist, and I entered the public health arena doing HIV risk reduction counseling in Long Beach, California, where we were doing one-on-one counseling to help provide people with information, works, food, and basically help them make whatever small changes they were ready to make to reduce their risk of sexually transmitted diseases. I met with homeless individuals, sex workers, and in retrospect, I think the most important thing I did was listen. So I realized a few things from my time there. One, people don't care about the information that I didn't care about the information that I provided if they were preoccupied with meeting their basic needs. So, why would someone with chlamydia, or why would anyone care about chlamydia if their environment is, violent? They're seeing their son murdered right in front of them on the street. They're selling sex to feed their kids. Second, if people don't have the resources to act on the information you provide, the information you provide is essentially useless. So if you want a job, well, you can't get a job if you don't have an ID, and you can't get an ID if you don't have a home. So it was really humbling to see people really doing their best and try to claw their way out of bad situations. And many would have if it not for the environment that kept putting up roadblocks, every step of the way. And the third thing that I realized is, once you understand where people come from and the horrific traumas that they've had to endure, it makes perfect sense why reducing the only comfort and escape that they have would be a challenge. So there's a lot more to why I do what I do. But that was the beginning of my realization that, we had it all wrong. And so the biggest influence on people's health are things, for the most part, out of their control. Yes, people have agency, but we all operate within these choice sets and they're restricted by our environment. And so I had this realization during a time when the country was spending way more money on law enforcement and interdiction to address a very treatable health condition than trying to address the demand for that drug. And now the overdose crisis has blown up and people in rhetoric are saying we're not going to be able to arrest our way out of this. But in practice, we are still very much, engaging in punitive approaches. And so there are all sorts of collateral consequences. So that leads me to what I'm doing today, which is, really focusing on those social and economic solutions for a social and economic problem and bringing to light all of those root causes and the solutions. That's really the guiding light of the work that I do at the center that I direct. And we're currently running a webinar series where, we're digging into all of that, looking at the social determinants of health related to prevention, treatment, recovery, and harm reduction. Looking at it from the policy angle, practice angle, programs, and people angles. So you can access, we have a lot of resources. If you're interested, if you go to the bit.ly link, SDOH webinar 2022.
Thank you. And on to you, Dr. Morrison.
Yep. Good afternoon, everybody, and thank you for the opportunity to be here today. So I like to tell my story that I grew up at the agency that I work for. That's called Brandywine Counseling and Community Services. We're statewide in Delaware, and Brandywine started off as part of a healthcare system and they were providing methadone services and had decided they didn't want to do it anymore. So we had incorporated. And that was probably about in the mid 80s. And then with the advent of HIV and AIDS, Brandywine added its street outreach component. So we've been doing Indigenous street outreach, harm reduction since that time. Delaware did not legalize syringe service programs until about 2007, I believe, or 14. So at that time, our Indigenous street outreach went from, bleach kits and condoms and talking to people about when you're ready for treatment were available, to being able to also provide syringe service kits. We also now are able to do the fentanyl testing strips, as well as HIV counseling and testing and hepatitis C counseling and testing. So there's a whole range of services. So Brandywine as an agency has really had to struggle with, as a treatment agency, and that, as you indicated earlier, the abstinence model with the harm reduction services that the organization had always provided. And, having that holistic approach and trying to deal with individuals all around needs, knowing that any kind of life struggle impacts all our different areas of life. So the social determinants of health. So it's been a very evolving process for us to integrate the harm reduction into treatment, as opposed to having it as two separate types of services. So I think that that's been a very, challenging and interesting development within the organization and the field at large.
Yeah, great to see so much deep roots in social services, which is where I got my start as well. So very near and dear to me. So switching gears a little bit, I know we are all non-clinicians here, but we work very closely with clinical settings or for places that offer clinical care. Why is harm reduction, in your opinion, important in a hospital or outpatient clinic setting? And we're going to start with you, Dr. Lattimore.
Let me unmute myself first. So, one of the projects that I worked on a few years ago was looking at folks who had overdosed, talking to them about why they had refused transport, if they had refused transport, and what sorts of services they needed instead of, if they weren't going to go to the hospital, what they needed instead. And by and large, the reason why folks refused transport to the hospital from EMS was because when they got to the hospital, they were highly stigmatized. By the way, EMS staff also said they were stigmatized by hospital staff because the emergency department staff didn't want them there. And so the individuals who had overdosed, waited in the waiting room for a very long time in severe withdrawal because they had been pumped full of naloxone, in withdrawal pain. And when they finally reached someone for care, they were again treated very poorly, often not provided the standard of care. And one of the most memorable things that I was told was one person, after all of that, got discharged with paperwork that said, these were the discharge instructions: stop using heroin, ! Underline. So if that's, why would you go to the hospital if that is in fact what you're going to get when you get there, after waiting a significant amount of time? Of course you're going to be like, no thanks. So that is why harm reduction is so important in the hospital setting, because you will not get the opportunity to support an individual and provide the care that is the standard unless they get there. And like 40% of people that are reached by EMS for overdoses refuse transport. On average, it's a little higher in some places, a little lower in others, but that's what we found. That's what's in the literature. And so folks really need to reconsider, their role in creating an environment that is more welcoming, and providing services that people need when they need them.
Yeah, in DC, we are at about 60% of refusal of transport. So it sounds like we're higher than average, which is not necessarily a good thing, but maybe an understandable thing. So moving on to you, Dr. Morrison, why do you feel harm reduction is important in a hospital or clinical setting?
Yeah, and I'm glad to hear that you all had done so much around stigma as part of your symposium, because it does infiltrate pretty much every area of treatment and can be the biggest barrier for individuals accessing, maintaining, and of course the family members are also impacted by that stigma, and then can also encourage or discourage individuals from getting treatment. So that stigma is huge, reducing it. And then if you can reduce that stigma, people access care, they'll be more or less likely to leave AMA, which is important in health outcomes. Having a collegiate and a positive experience with a patient is good for the patient and the clinicians, right? So it increases and improves everybody's clinical experience. I think, we know that the hospitals and the ED, unfortunately, are still the primary place where a lot of the individuals suffering from significant addiction issues obtain their physical health care. So again, the more positive experiences they can have there, the more we can get them linked into primary care and hopefully, preventative care, that we all would like to increase health outcomes. And we're advancing health knowledge, healthcare knowledge by getting people and doing harm reduction. That's what I would.
And on to you, Dr. Reed. I know you've been working most closely in an emergency setting. So why do you think harm reduction is important in a hospital setting?
I mean, I don't think it'll come as a surprise to anybody that people who use drugs have pretty frequent contact, as Dr. Morrison was just saying, with the healthcare system, especially with emergency departments, or even having to be inpatient, whether that's because they've experienced an overdose and so they're brought in, or because they are experiencing, endocarditis or some sort of skin infection that's directly related to their drug use, or if they have some other comorbidity with their substance use. People use drugs might be in there for a diabetes related reason or a heart condition that's not directly related to their drug use, but the physician and the rest of the clinical staff working with them has to kind of co-manage both conditions at the same time. I've done a lot of interviews recently with hospitalists about their experiences working with people with opioid use disorder. And, you know, these are people who really, really care about the patient population and who also feel really frustrated sometimes because they can be more complicated patients to manage all of their needs. So with, you know, the ubiquity of fentanyl in the opioid supply, treating tolerance and treating pain with the available medications that we have is just increasingly difficult. And it leads to patients, you know, having self-directed discharge and then being rehospitalized. And then we know, as you know, the other panelists were saying, that people who use drugs experience a lot of stigmatization from hospital staff. And so they oftentimes compare the experience of being inpatients to incarceration, which is not great, right? So it explains why people are more likely to leave. Care outside of the hospital is difficult, right? So if you bring in a harm reduction focus, it's kind of inherently trauma informed in its approach as well. So you're really meeting people where they're at, and you are letting go as the clinician of your own expectation of what this person's going to be doing, and you're able to work with them more directly with their own very specific needs that they may have. And I think it's, again, really helps with staff burnout a lot who have a harm reduction approach, because they're not being constantly frustrated and feeling like they're hitting up against a wall. And then it's our job, I think, as harm reductionists to bring those tools to clinical settings so that, you know, clinicians who feel like they often don't have those tools to offer patients have those tools, both to just give them something, you know, that's, you know, tactile, like hand them a tool, but that also opens up a conversation and really improves the clinical relationship.
Great. And before we move to our next question, I forgot to mention, please put your questions in the Q&A. We've got a couple, but we will hopefully have time at the end to answer some. So please give us your questions and we'll answer as many as we can towards the end of the panel. So going back to Dr. Morrison, what is an example of a harm reduction based initiative or intervention that you have seen or been a part of, either within the hospital or within outpatient clinical setting?
Sure. So as I mentioned, Brandywine was part of a healthcare system when we first came about, and we've maintained a very close relationship with them. I've been part of the organization, Brandywine, for over 20 some odd years, started out as a counselor and moved my way up. So as my predecessor had a good friend who worked in the hospital, and he was noticing a lot of repeat individuals, and this is back 10, 15 years ago, that were falling. They were coming in for head injuries, but they also smelled like alcohol or, you know, other ailments that were happening with an individual, but you could probably tie them directly to their use. So he said, how about bringing some of your staff into the hospital to do hospital bedside interventions? So I know this is almost fairly common now to have the peers embedded inside the hospital system. So Brandywine was one of the first to be part of that with Christiana Care Hospital System in Delaware. And that was wildly successful. It really helped on a whole lot of levels that we've been talking about, introducing people to the idea of treatment who never maybe even thought about it before, as well as just talking to somebody who could share their experience and also almost act like a translator with the hospital system. Often the communication is, you know, from a professional to a peer can be a bridge that they can help gap in the patient setting. So we found that to be extremely helpful, as well as the stigma that we've all been talking about. As the hospital workers get to know the peers then share their stories, and they remind the hospital system that I was that person in that bed. I was just like them. And, you know, with care and people who loved me and supported me and worked with me, I was able to move into recovery. Now, again, that's not for everybody. Everybody doesn't want total abstinence, and we have to be okay with that. And so the conversation shifts from, what do I expect, as was mentioned earlier, as to what does the patient want? What do they want out of their lives? And the conversation shifts to, well, what tweaks and changes can you make to your world in order to be able to attain your goals? And often, it relates back to behaviors that are related to substance use. Sometimes not. Sometimes it's other stuff. But those peer experiences being embedded in the hospitals position them now to be able to create pathways with Brandywine, where they're able to initiate individuals at the hospital level on buprenorphine with a direct connection to our organization for outpatient services, so that there's no gap in care. I know in the hospital systems, a lot of the concern is, okay, now I've identified it and I need to be able to provide them with the next level of care. What's out there? What organizations can then help me? So we've been working very closely with the hospitals to create those pathways so that the ED and inpatient settings know exactly where they can send individuals, and from one day to the next, the individual knows where they can go to get continued care. So those are some of the things that we've been a part of and are very excited about.
Great. And on to you, Dr. Reed. I know you've done a lot of work in the hospital. So what has that looked like where you've worked our harm reduction interventions in that setting?
My favorite project that I think other hospitals can implement as well. I was doing work outside of the hospital in the community, talking to people who had ever used fentanyl test strips, and just doing a study on fentanyl test strip practices, especially when people had used fentanyl test strips on drugs like powder or crack cocaine, to see how often those drugs were testing positive for fentanyl contamination. So, due to fentanyl, the presence of fentanyl in the drug supply, harm reduction programs have been giving out fentanyl test strips. They cost about $1 each. And I was asking people, how are you using them? Found that people were rationing their use. They weren't getting them from enough places, and that they really need to be receiving about 20 at a time to meet their needs, right? Because especially with fentanyl, you have to inject more frequently because it runs out more quickly. So if people wanted to test their drugs and see if it had fentanyl in it, they probably needed to be testing more frequently. Anyways, in asking people where they would like to receive fentanyl test strips, a number of them said at the hospital, in the emergency department. We go there pretty often. It's a touch point for us. And since that's where I happen to be located, I went to my department and I said, hey, could we start giving these out? And they said, that sounds great. So we got funding for the fentanyl test strips and to do a study about their implementation. And that's what I've been working on for the past 7 or 8 months. So we did a pilot program where we distributed fentanyl test strips for 3 months, and we interviewed staff twice. We recruited staff across different levels of the ED. So we recruited attendings and residents and nurses, a social worker, a technician, and some certified recovery specialists. So those peers that Dr. Morrison was just talking about. And when they saw a patient who used drugs, they offered them fentanyl test strip training and then a pack of 20 fentanyl test strips. We interviewed that staff twice, once at a few weeks and once after 3 months, to see how acceptable the intervention was to them, how it fit in with their workload, how it impacted rapport with patients and the overall patient relationship, how they identified patients, how they had the conversation, et cetera. And we found that, all staff at the end of 3 months were glad that they were doing it. It will come as no surprise that EDs have been particularly chaotic in the past couple of years. So they talked a lot about competing demands. So the main recommendation I would make for EDs doing this is to put the fentanyl test strips in a visible place, so that it's just kind of like a cue to action, a reminder for staff to offer them to patients, or to have a laminated card somewhere, or on the Epic printout to have something where it triggers a recommendation for patients to receive and to be trained on the use of fentanyl test strips. We also surveyed patients during this time period, approached patients who were identified as patients who use drugs, and asked them if they wanted a survey. These were research coordinators we have in the ED. And at the end of that survey, We asked people about their drug use practices, what they knew about fentanyl, if they knew about fentanyl test strips. And then we also asked people, do you want to be trained on these? And, do you want them? And 100% of the patients that we surveyed wanted them. So there is this desire among patients to use fentanyl test strips. So that's a successful intervention. We're continuing to offer them in our ED and increasingly to inpatients.
Awesome. Yeah, I know we've been consulting you a lot in DC to learn more about how you've rolled that out. And so on to you, Dr. Lattimore. What's an example that you have seen or worked on in terms of harm reduction in a clinical setting?
Yeah, so Megan, just mentioned that there are, a lot of folks are coming in for overdose, substance use disorder, and that's, overdose deaths are through the roof. Overdoses, non-fatal overdoses coming into the hospital have particularly increased since the pandemic. And so, we know that medications for opioid use disorder save lives. But my colleague Josh Brockus demonstrated through some of the research that he's done that providing medications for opioid use disorder and bridge prescriptions in the hospital saves lives, reduces hospitalizations, and is cost effective. And if you add on to that, the infrastructure that's needed through addiction consult services, that saves even more lives and reduces hospitalizations even more, and it's still cost effective. So, that's one thing that that we've seen work. And, providing naloxone and brief intervention is also a standard of care, but, providers feel constrained by time. They feel constrained and feel under-skilled to do that often. And so again, hospitals need to build in that infrastructure to make these harm reduction tools work. So finding a way, since it is cost effective to do the addiction consult, is worthwhile. And then obviously we've got peers work, but to really make the most out of peers who can support physicians and individuals who come in through that, experience that patient-centered approach. In order for that to be effective, you truly need to integrate peers into the workflow, pay them enough, give them enough hours, and really recognize them for the important contribution that they make to the team. And we shouldn't be restricting access to those harm reduction tools, any of that, peers, any of it. We shouldn't restrict access for those who aren't ready for treatment. And maybe that may not be their goal at all. So.
Yeah, I think some of the things you touched on is a really great segue to our last question. So starting with Dr. Reed, what are some of the challenges to advancing harm reduction efforts within the hospital system or clinical practice?
Wish there weren't so many, because I feel like I'm about to make a very depressing list, but they can all be overcome. The primary one is stigma, which I see some people in the Q&A are asking about to an extent. And I do think stigma is addressable. Just through more engagement with patients. I think engaging with patients in a harm reduction manner will decrease stigma just kind of automatically as you have more favorable interactions with people. I also know that, hospitalists that I've interviewed are willing to do new things, but they want a very clear protocol. So we need just clear protocols written and put into place so that when somebody sees a particular type of patient, that protocol is just automatically triggered for them. So some of these are really, really easy fixes. The nature of the ED makes doing harm reduction interventions difficult. People are just pulled in way too many directions. The physicians felt like the nurses should be doing it. The nurses felt like a social worker or a physician should be doing it. Everybody feels it's really important to do and they all want to do it, but they don't know how to fold in harm reduction into what they're already doing. So what that means really is we need additional staff who are trained specifically in these issues. We need addiction medicine consult services. We need more certified recovery specialists. They are essential to working with patients who use drugs in our hospital system, but we only have a few and we don't have 24-hour coverage. And, when I meet with my colleagues across the hospital system, that's the number one thing that they all cite is that they need more certified recovery specialists. And I think getting hospital administration and leadership to buy into what Dr. Lattimore was just talking about, this is all very cost effective. We have to make an initial investment and have a social worker or have a harm reduction nurse who can talk to patients about safer injection and wound care after they leave the hospital. You know, a lot of people who leave the hospital who might have endocarditis or need really complicated wound care can't find an outpatient facility that will accept them. And so they might be going back to living, you know, staying on somebody's floor in an apartment somewhere and having to take care of a really complicated wound. I mentioned the difficulties that fentanyl has presented, but we also have a really bad xylazine issue here in Philadelphia. And I imagine it's increasingly being seen where y'all are. And that's associated with much more frequent hospital visits, really bad wounds. We've been doing a lot of amputations. And again, these patients need really, really complicated care. So I think more bridge clinics to transition people out of the hospital successfully and to keep them on medication once they've been stabilized on medication for opioid use disorder within the hospital. Those are all things that will really help. And kind of overarching is the issue of stigma, which I think we just need to chip away at.
Yeah, for sure. We are starting to see more xylazine in DC, not to the extent that Philly has, but it's definitely caught us a bit flat-footed. But if you want to learn more about harm reduction for xylazine, quick plug for our Live Long DC Summit next Wednesday. We'll be talking about that. So on to you, Dr. Lattimore. What challenges have you seen in advancing harm reduction efforts within hospitals?
Yeah, well, my answer was stolen. Stigma. I think it's going to be all of our, first and foremost, our answer. Dr. Reed mentioned that, you know, the exposure to people with substance use disorder, and a key element of that is a humanizing exposure to people with substance use disorder. And an experience of seeing people recover or get better from the acute condition that they were in. You know, EMS constantly see folks who are in stressful situations, and there's a lot of stigma there too, because they never get to see the person access treatment or some other, you know, socioeconomic resources and get their life back to, you know, a certain level of quality. So stigma can be addressed through, you know, humanizing exposures. It can also be addressed. Some of my colleagues at Hopkins, Elaine Kennedy Hendricks and Beth McGinty, they did some work to, one, quantify the stigma of folks in medical professions. And then they also tested some visual communication campaigns. And they showed that when folks were showed the value and effectiveness of medications, and also the impact of stigmatizing language like addict and dirty, and I mean, there's a whole list. When folks were, that information was shared with the medical staff, that actually decreased negative attitudes. And I think also another challenge is the focus on biomedical perspectives. So for, you know, the reasons I mentioned in the beginning of the session about folks having restricted choice sets based on their social and economic environment, you know, we really need to, you know, obviously we shouldn't throw away the biomedical, you know, some of the components of a biomedical model, but integrating into that, understanding the context in which your patients are living in will only improve your ability to serve them. And so tools like peers and having CMS authorization for the use of peers in every state. You know, there's a harm reduction is healthcare toolkit from the National Harm Reduction Coalition that talks about financing, you know, and removing the X waiver. You know, now we still have an X waiver for those who are prescribed to more than 30 patients. And so there are some policy barriers that are preventing us from being able to truly support folks who come into the hospital.
And finally, Dr. Morrison, what challenges have you seen in advancing harm reduction within hospitals or clinical settings?
Yeah, so I was going to say my expertise is more in the clinical setting than in the hospitals. But I will say one of the things that we've been talking a lot about in Delaware is the pharmacy challenges that with the workforce shortages that we're all experiencing everywhere, pharmacies are now, not open 24/7. They're closing on the weekends. And so if you get a prescription from the ED on a weekend for buprenorphine, let's say, they don't necessarily have a place to fill that prescription. So making sure that there's, again, those pathways and connections with the community resources to be able to do the follow-up that's necessary if someone has said, yeah, I want to continue to try this medication, or I am ready to get into treatment, or whatever that would be. So I think that, again, that linkage between and the work that is created, and that's why I advocate along with the other doctors in this, for the peers and the certified peer involvement, so they can do a lot of that, legwork. They're very familiar with the treatment system, because the treatment system is still growing and developing and making itself more accessible, and overcoming the challenges that we have in order to be able to help the hospitals do what's being asked of them. So I think, continuing those communications and working with the treatment system to get us up. The other thing that Delaware struggles with, and I'm not sure is, where in the other states, is that fentanyl strips are considered paraphernalia in certain laws. So I will say that the police have been not, going after it, but it still shows how the stigma and how, Dr. Lattimore talked about that, it's still criminalized to such a great extent that it's so ingrained in our systems. And a lot of states also have limitations around syringe services, 1-for-1, or, you can only, you can only get one if you give me one, and all of those kinds of restrictions that, again, limit people's availability to things that we know reduce physical ailments and that kind of thing. So, I think that's probably a good summary of of some of the challenges we see.
Thanks. Yeah. And so before we get into our Q&A, and I'm excited to see so many questions in the chat, I'm just going to ask each of our panelists in one sentence, what is the hope that you have for the future of hospital-based harm reduction? I'll start with you, Dr. Lattimore.
Yeah, I love this question. So my hope for the future is that people recognize the huge number of negative collateral consequences of the war on drugs, and how it's time. We must do something different than what we have been doing. And that they realize how the war on drugs is driving stigma. If drugs are illegal, then people who use drugs are, and that informs the way people think about people who use drugs and people with substance use disorder. But this is all a fallacy, because alcohol is a drug, yet it's legal and regulated and safe. And it's, there are still overdoses from alcohol, but we know, because Prohibition happened, alcohol used to be illegal, we know that we would be experiencing more deaths if alcohol was not regulated. Back then, people were dying of bathtub gin. And so, the risk profile for things that are legal and not legal really does not match the law. So my hope is that we construct laws that make sense. There are 641 collateral consequences of nonviolent drug conviction, and this has consequences on employment, professional licensure, transportation, public benefits for food and housing and loans. And so, we really need to take a real hard look at whether or not our laws make sense, and look at ourselves and within ourselves and do some, checks about why, if you're having negative feelings towards someone who uses drugs, where is that coming from? And how much do our nonsensical laws contribute to that?
Great. And on to you, Dr. Morrison. What is your hope for the future of harm reduction in hospitals?
So
And not hospitals.
I'm so operational compared to what Dr. Lattimore said, but harm reduction kits for a whole array of substances available at every level of the hospital system. So I know Dr. Reed talked about the fentanyl strips being available, but we can create kits for different substances that individuals use with harm reduction, either materials, educational materials, and other supplies, if you will, that would help. So that's my wish and my goal.
And finally, Dr. Reed.
I think the only way this ends is if the war on drugs ends and if we have a safe supply and a regulated supply of drugs, to be fully transparent. And so my hope is that we work more towards recognizing that that's the most pragmatic solution to this problem or these problems that we could possibly have.
If I can interject my own personal hope, right now it is so much easier to buy drugs than it is to access treatment or supportive services. And so my hope for the future is that it will be just as easy to access treatment and services, or easier than it is to access drugs. So moving into Q&A, I think we'll just popcorn it. I'm going to start with a really interesting question. Is all harm reduction aversion rooted in stigma, or are there other reasons why somebody might be against harm reduction practices?
Well, I mentioned the biomedical model, and if what you believe is that there's something in the body that is broken, and that only taking that drug out will put things back in order, will establish homeostasis, then you're going to be your set of choices, your menu of options for that solving that problem is going to be very medical. And we know that even when you remove the drugs, people still have, and they could have been recovered for years. They still have challenges, and they're often triggered by socioeconomic conditions. And so expanding beyond the biomedical approach, or if you focus on only the biomedical approach, it will be difficult to really accept, a harm reduction model.
I would also add that I think a lot of people are, in the industry enabling. They see harm reduction as enabling somebody or giving them permission. and that's kind of a perspective that people need to shift inside themselves, to say that people have choice and they are going to make the choices that they need to make for themselves based on whatever's going on inside them. And as Dr. Lattimore said, sometimes that is so complex that they may not even know. So just having a level of acceptance and accepting somebody for who and where they are can open up a whole new world to them that they didn't even know about. So, it's not enabling. You're accepting somebody and the choices that they're making for the life that they're living. And then saying, how can I help you achieve the goal that you want? Where enabling is something quite different.
I'm going to combine a couple of questions. So what are ways, we've talked a lot about the role of stigma within the medical setting, but we haven't talked so much about how we break that down. So what are some ways that clinicians and non-clinicians can support harm reduction practices, and is empathy training a part of that?
I know that I think a lot of it's training and kind of baking that training into clinical training programs. So, a lot of med students have to attend patient panels from patients with certain conditions. And we've started having patient panels of people who use drugs to talk directly with students, either in like roundtable sit downs or in kind of like a more traditional panel presentation. It's really helpful and it should be required. You know, I think more and more clinical programs are building competencies into their programs of working with people who use drugs. So I think that will help a lot. And I think just recognizing that people who use drugs are not just simply reduced to their drug use, right? That they are, you know, complicated people with dignity. You know, I think the more that we just interact directly with people who use drugs, and also interrogate the inner voice that's having that kind of moral knee-jerk reaction, those things will all really help our own stigma, and then we'll be better advocates for others.
Yeah, the only thing I would add to that is stay curious, right? Which is just another way of kind of reiterating what Dr. Reed just said. Just stay curious, ask questions, don't assume you know why someone's doing whatever it is that they're doing. And if you are genuinely interested in the patient and their experience, that will come across, and that in and of itself will defeat that stigma and help with harm reduction, introducing it.
I'll just add to what folks have already said, by recognizing how much equity and racism kind of fold into all of this. You know, Dr. Reed talked about intersectionality, and, you know, folks also face, you know, a lot of racism in through drug policy and in equitable implementation of drug policies. And so faced with drug policy, racism, medical, you know, implicit bias in the medical community, I think really, you know, part of meeting people where they are is also recognizing the experiences of racism and being culturally competent, and providing services that meet their needs. And so that includes thinking about equity.
Great. I think we have time for one or two more. So one of the other questions we received is, what about specifically in terms of stigma and unhoused or unstably housed individuals? How do we bring services to that population? And what have you seen locally in terms of that being done?
The housing first model, I think, has a lot of research and support around it. So, you know, not using someone's current history or use patterns to determine whether they can or cannot have housing. I think our greatest challenge with housing is just availability. I mean, we don't even have enough of it. It just doesn't exist, and it's a huge problem. Just that, and then once we get past that, going to housing first, not using people's use against them.
Well, in my work with folks who refuse transport, one of the things that people said, you know, those that did not want to go to the hospital said that stabilization centers and you know, transport with peers would be helpful. And so if you are hoping to get a marginalized group of people into the hospital for care, providing some steps up that may not be straight into the hospital, but meeting them with peers, or providing a interim service that feels more comfortable and welcoming while the hospital is sort of making the changes that might be needed to provide the same kind of environment, could be really helpful.
Great. Yeah, that touched on one of our other questions of how do we improve transport, and it sounds like the answer is options that are not necessarily just the hospital.
Right.
Finally, in our last couple of minutes, I'm going to ask about legislation. So how can we organize or encourage organizing for legislative changes at local and federal level, both within and outside of the medical system?
Well, I'm not a community organizer, but I have talked to a lot of public officials, and the thing that helps the most is data and stories. And so if you can get folks like an epidemiologist and clinical people together to frame the story in a way that makes sense to public officials, and that's with data, very straightforward data and stories, the messages sink in.
And so this is probably, I think this is the only genuinely bipartisan issue I can think of. So we're in like a luckier position where the solutions aren't always agreed upon. But I think pretty much everybody recognizes at this point that the war on drugs has failed. And increasingly there's a recognition that the war on drugs is racist and classist and has ripple effects for not just people, but generations to come within those families. And I agree, stories and data are really helpful in helping people think through what the solutions are. Because sometimes the solution is to be more punitive again. Like in Colorado, there's legislation that I believe just got passed that makes possession of really small amounts of fentanyl criminalized. And we know that a criminalizing approach doesn't work, it causes more harm. So I think using data-driven solutions and then amplifying the voices of people who use drugs can go a long way.
Yeah.
And I'm sorry, actually, I said clinicians to tell the stories, but you're so right that people with their direct experience would also be, yeah. Mm-hmm.
The only thing I would add with that, from a provider level, we're involved in providers joining provider groups. So, you know, on the local level, and then the National Council for Mental Wellbeing, they do a lot of advocacy on the federal level, and, you know, have so many state representatives that it can really help move the needle in needed legislation. And I know they're starting to pay particular attention to harm reduction and where it falls in this whole, you know, dynamic of helping individuals who suffer from substance use.
But the bright spot is that, you know, the Office of the National Drug Control Policy budget, at least the request, has finally switched over from a primarily interdiction, you know, funding approach to, you know, now there's more, the percent of the budget is now more on the demand side than the interdiction side. So that's encouraging.
Great, thank you. I'm sorry we didn't get to the last couple of questions, but we are out of time. So I believe Eden is going to introduce the next session. Thank you so much again for having us all here today.
Thank you, everyone.